Hello and welcome to the Common Rounds. In today's cardiovascular talk, we'll be covering hypertension. Hypertension is considered a state of elevated blood pressure, and our blood pressure is composed of two components: the systolic pressure, which is the pressure experienced by the body when the heart is contracting, and there's a diastolic pressure, which is the pressure within the arteries when the heart is relaxed. A normal blood pressure is considered to be less than 120 for the systolic and less than 80 for the diastolic. You can also have a pre-hypertensive state where the systolic blood pressure is between 120 over to 139 and a diastolic pressure between 80 to 89. Now, once a patient's been diagnosed with hypertension, that can be divided into two stages. Stage 1 is considered a systolic blood pressure between 140 to 159 and a diastolic pressure between 90 and 99. And stage 2 is considered systolic blood pressure greater than 160 and a diastolic blood pressure greater than 100. You can have hypertensive urgency, which is systolic pressure of greater than 210 and a diastolic pressure greater than 120. And malignant hypertension is a severe form of hypertension when the patient's experiencing papilledema, retinal hemorrhage, or other vascular or end organ damage manifestations. Hypertension can also be classified into primary, also known as essential hypertension, which accounts for majority of hypertensive cases, and also secondary hypertension, which has an identifiable cause. Before we talk about the pathophysiology and the pathogenesis, I just want to briefly cover some physiology concepts. So cardiac output is considered to be a product of the heart rate and stroke volume. And stroke volume is the amount of blood ejected from the heart with each contraction. And it's influenced by how much blood is returned to the heart, so the venous return, and the resistance against which the blood pressure or the heart has to contract against. Now, a blood pressure is a product of the cardiac output, so how much blood is being ejected from the heart, as well as the resistance within the vasculature, also known as total peripheral resistance. And blood flow is dependent on the pressure as well as the resistance in the arteries. And finally, resistance is a product of a number of factors, including blood viscosity, the length of the arteries or the arterioles, as well as the radius. So for example, if the radius is decreased within the blood vessels, resistance increases drastically. So with some of the basic physiology out of the way, let's talk about some pathogenesis. As I've alluded to, essential hypertension is a type of hypertension where we're not sure what the cause is. It's related to a number of factors, including lifestyle factors such as obesity, diet comprised of high sodium, smoking, and decreased daily physical exercise. Secondary hypertension, on the other hand, has a number of causes. It can be due to renal factors such as glomerulonephritis or polycystic kidney disease. It can be due to endocrine causes such as pheochromocytoma, which is a tumor of the adrenal medulla chromaffin cells, which release noradrenaline and adrenaline, leading to increased vascular resistance and cardiac output. It can be other causes, endocrine causes such as primary hypoaldosteronism, where you get aldosterone causing sodium retention and intravascular volume expansion. So that way there's more blood coming back to the heart, which is resulting in greater cardiac output and greater blood pressure. There can be also vascular causes such as vascular stenosis affecting the renal arteries. This leads to activation of the renin-angiotensin-aldosterone pathway, resulting in sodium retention, volume retention, and vasoconstriction. And let's not forget medications such as pseudoephedrine, which can be commonly taken for cold and congestion, which is a sympathomimetic agent. Now, looking further at pathogenesis, hypertension is a problem because it can affect the arteries and the arterioles in a number of ways. It can accelerate arterial sclerosis, leading to progressive occlusion. Hyaline arteriosclerosis can occur where the arterial walls are affected by hyaline changes, which causes the walls to be weaker and more vulnerable to rupture. And this is why hypertension is such a problem when it comes to cardiovascular disease and neurological factors such as stroke. Now, hypertension can also have a number of organ-specific complications. So as I've already alluded to, cardiovascular complications can result in ventricular hypertrophy because the heart is pumping against significant pressure. This can lead to decreased efficiency of contractile fibers over time, can result in ischemia of the myocardium, and long-term can lead to congestive heart failure. Now, over time, this reduction in cardiac output can be observed. As I've already alluded to, you can see an enlarged ventricles, or can lead to enlarged atrium and subsequent development of arrhythmias, such as atrial fibrillation. As I've already alluded to, cerebrovascular factors can also occur, where you get potential increased risk of blood vessels rupturing and hemorrhagic stroke, as well as renal impacts, including damage to the glomerulus, glomerular sclerosis, and progressive reduction in renal function, so ultimately end-stage kidney disease. In terms of signs and symptoms, essential hypertension is often asymptomatic, so it's a silent killer. Screening is really important, and according to the Australian College of Physicians, blood pressure should be measured in all adults from the age of 18 at least every 2 years. And after the age of 45, blood pressure should be managed with respect to cardiovascular risk stratification, which I'll allude to shortly. Before we talk about more of the screening side of things, let's talk about some of the diagnostic approaches. So a differential diagnosis really relates to ruling out secondary causes of hypertension, as I've already mentioned. For example, ruling out endocrine causes, ruling out renal causes. It should be particularly considered if we see hypertension in the really young, so patients aged less than 30, if they present with malignant hypertension, or if they have refractory hypertension, so they're patients on at least 3 antihypertensives and their blood pressure remains elevated. Let's go back to screening. According to the Royal Australian College of General Practitioners guideline, we can divide our screening strategy into patients with low risk cardiovascular disease, moderate risk, and high risk. So for those with low risk, we can provide them with lifestyle advice, and if the blood pressure is greater than 160/100, we can consider pharmacotherapy. And we measure their blood pressure every 2 years. For those with moderate risk, we provide intensive lifestyle advice and provide pharmacotherapy if we have no improvement after 3 to 6 months, or start pharmacotherapy straight away if their blood pressure is 160/100, or if there's a family history of cardiovascular disease, or they're at risk population group. And we measure their blood pressure at least every 6 to 12 months. For those with high risk, though, we provide intensive lifestyle advice, but also start pharmacotherapy straight away, so we don't wait to see how the lifestyle advice goes. We also start antihypertensive therapies in patients without any cardiovascular risk factors, but those with chronic kidney disease as well. And again, we measure their blood pressure every 6 to 12 months. In terms of investigations that we need to do, as you can already gather, blood pressure measurements are important. We measure blood pressures in at least 2 occasions. At the first assessment, though, we measure blood pressure on both arms, and we use the arm that gives us the highest value that we've obtained from the measurements. Patients with orthostatic hypertension, we need to measure the blood pressure in a sitting position, then repeat that when the patient is standing after about 2 minutes. A second visit should also be conducted within a month so we can recheck those values and, if necessary, provide advice or treatment. We can also consider the use of ambulatory blood pressure monitoring or self-measurements for patients with any of the following factors. For patients with variations in their blood pressure readings in the clinic, those with suspected white coat hypertension, so patients who come and see their doctor and the stress of the process causes their blood pressure to be elevated, or those with pharmacotherapy-resistant hypertension. Other investigations that we need to consider often revolve around ruling out secondary causes, looking at blood biochemistry, at the patient's renal function, serum sodium, and potassium, looking at their fasting lipids for potential lifestyle interventions that we can provide, looking at patient's thyroid function, looking at urine analysis to see whether there is any protein leakage from the kidneys, looking at 24-hour urine metanephrines. For example, we're considering in this situation patients with pheochromocytoma, looking at plasma aldosterone to renin ratios to rule out hyperaldosteronism, and also consider imaging. For example, when we are worried about renal artery stenosis, looking at renal artery ultrasounds and echocardiogram if we're worried about cardiac remodeling. So in terms of treatments that we can start, as I've already alluded to, non-pharmacological treatments are important. So encouraging the patient to increase their exercise, encouraging them to give up smoking, limit their alcohol intake, and limit saturated fat and salt intake. If patients have applied that and their blood pressure is elevated, as per the guidelines, we can then consider pharmacological intervention. Now, what's important here is not the agent that we use, but rather the degree of blood pressure lowering. And the choice of agent really depends on other comorbid conditions as well. For example, whether the patient has left ventricular dysfunction, renal disease, or ischemic heart disease. But in general, there are a number of first-line agents that we can consider. So thiazide diuretics are a cheap and safe option. They reduce sodium reabsorption in the renal tubules and thereby reduce fluid reabsorption as a consequence. Be aware though, these drugs can cause hyperuricemia and insulin resistance, so their use in patients with gout and with diabetes has to be done with caution. ACE inhibitors or angiotensin receptor blockers are another good option. They can decrease the activity of the renin-angiotensin pathway and thereby decrease vasoconstriction, fluid reabsorption, as well as sodium reabsorption. Their combination is contraindicated because it's been shown to increase the risk of nephrotoxicity, including end-stage kidney disease or acute renal failure. And they're also contraindicated in pregnancy. Calcium channel blockers are another option, and in this case we have 2 types. We have the dihydropyrimidine agents, so these include things like amlodipine, nifedipine, and these bring about about muscle relaxation, hence vasodilation, and reducing peripheral resistance. Another option is the non-hydrodihydropyrimidine calcium channel blockers like diltiazem. These are more cardioselective and are negative inotropic agents, but they're contraindicated in patients with heart failure. Second-line agents that we can consider include beta blockers, such as metoprolol. These can be first-line agents, so in patients with left ventricular dysfunction or ischemic heart disease. Prazosin can also be considered, which is an alpha-1 blocker. Moxonidine and nitrates may be other options to consider as well. So in patients with uncontrolled hypertension on monotherapy, they can have a better response with the addition of a low-dose second agent rather than increasing the dose of their monotherapy agent, which brings about potential increased risk of side effects. So in terms of our treatment goals, we have to push the patient as much as they can tolerate. And in general, we aim to reduce the blood pressure to less than 140/90 for adults without cardiovascular disease, including those with chronic kidney disease, and aim to reduce the blood pressure to less than 130/80 for adults with diabetes or with proteinuria. This brings our presentation to an end. We hope you enjoyed it. If you have any questions or comments, get in contact with us through Facebook, YouTube, Twitter, and our website.